Welcome to this clinical explainer. Today, we're jumping straight into the shoes of an attending physician, and we are looking at a Step-3 challenging clinical scenario. This is hard mode diagnostic reasoning, guys, so let's get right into it.
All right, so here's our patient presentation. We've got a 78-year-old guy with a known history of hypertension. He's been dealing with some exertional dyspnea, and here's the absolute kicker, he is now presenting with episodic dizziness and near syncope, specifically when he's walking uphill. You really want to pay attention to that alarming progression right there. Walking uphill is a massive red flag that his cardiovascular system is just flat out failing to meet that increased physical demand. Okay, moving to the physical exam, and honestly, this is where the magic happens. You check his pulse, and it is slow rising and weak, right? This single critical hemodynamic clue is your anchor for solving this entire case. Some of you might be thinking of the classic term pulsus parvis retardus, but honestly, whatever you want to call it, a slow rising and weak pulse tells a very specific mechanical story about the blood flow leaving this guy's heart. So let's methodically layer on the rest of the findings here and watch how they interact. Blood pressure is 110/70. He's got a harsh systolic murmur right at the second intercostal space, but notice this, it is barely audible over the apex. It's super localized. Plus, we've got that delayed carotid upstroke, a soft A2 sound, and his ECG is showing left ventricular hypertrophy, or LVH. Every single finding here is a deliberate breadcrumb. So, what is the most likely diagnosis? Is it A, hypertrophic obstructive cardiomyopathy, B, severe aortic stenosis, C, mitral regurgitation, or D, aortic sclerosis? I actually want you to pause for a second, think strictly at a Step-3 level, and lock in your answer. Which of these perfectly marries exertional syncope with a localized murmur and that uniquely weak pulse? Take a second. Got it? The definitive diagnosis here is B, severe aortic stenosis. Now, if you nailed that, awesome job. But if you didn't, don't sweat it, because you probably fell for a brilliantly designed trap. The exam writers literally built this to make you impulsively guess HOCM. I mean, LVH plus syncope. On the surface, that looks like a slam dunk. But here's the differentiator. If it was HOCM, that murmur would increase with a Valsalva maneuver, and we just don't see that here. The reality is severe aortic stenosis. It perfectly explains his exertional syncope because it's a fixed cardiac output problem. He walks uphill, his body screams for more blood, but that severely narrowed valve simply cannot deliver it. And that brings us to the true hallmarks of aortic stenosis. A murmur at the right second intercostal space that radiates to the carotids, paired with a slow rising pulse. That is the classic signature. Also remember that soft A2 sound we mentioned? That's a massive clue indicating a heavily calcified valve. The A2 sound comes from the aortic valve snapping shut, right? Well, a severely calcified, stiff valve creates a physical roadblock. Because it's so rigid, it doesn't snap shut properly anymore. That's exactly what gives us that soft or indistinct A2, and of course, that notoriously weak pulse. Just to be super thorough here, let's rapidly eliminate the other options. Mitral regurgitation, exclude it immediately. An MR murmur is holosystolic, it radiates to the axilla, and it's loudest at the apex. Our patient's murmur was barely audible down there. Okay, what about aortic sclerosis? It's a great distractor, but we rule it out because sclerosis typically presents with totally normal hemodynamics and zero symptoms. Our guy nearly passed out walking up a hill, so he is dangerously symptomatic. So, as we pull all this together, I want you to burn this high-yield Step-3 pearl into your brain. If a murmur radiates to the carotids and the pulse is slow rising, it is AS until proven otherwise. Seriously, it really is that straightforward. Lock this pearl away. It's going to save you so much time on exams and stop you from second-guessing yourself on the wards. Thanks for working through this explainer with us and honing your diagnostic reasoning today. Make sure to follow Beyond the Ward MD for your daily Step-3 exam traps. But before you go, I want to leave you with this. The next time you're faced with a really loud, distracting cardiac murmur, will you remember to let the quiet, weak pulse guide you to the true diagnosis? Keep questioning, keep learning, and we'll see you in the next explainer.